Yeah, good afternoon all. Today for a guest, can you hear me?
Yes.
Hello. Yeah.
Yes, sir. Proceed, sir.
Yeah. Good afternoon. Good afternoon, everyone. Welcome all participants from different parts of South India. Today we are very much pleased and grateful to have Dr. Shoba Subramniam as a guest speaker for the day. She will be speaking on ABG, the basics, and how we can simplify it, and how we have to approach to different acid-base disorders. Dr. Shoba Subramaniam was here with us at Amala department in pulmonology for a couple of years, more than 15, I suppose. And then right now she is a professor at pulmonary medicine department at Amritha, Cochin. And we are very much pleased to the ABG can be simplified by an experienced pulmonologist from Cochin, and welcome you all for the topic, and I welcome you, madam, for the rest of the proceedings. Over to you, ma'am.
Yeah, sure. Hello. Can you all hear me? Good evening to all.
Yeah, ma'am, we can hear you.
Yeah. Arterial blood gases, they form an important investigational tool for very critically ill patients. It can be done in the medical wards, in the ICU setup, in the post-operative care room, in the emergency room. A good knowledge of arterial blood gases is a must for all physicians, especially the pulmonary physicians, as well as intensivists, the anesthesiologists. And I think all medical personnel should have a clear idea of how to approach arterial blood gases. As we all know, it helps us in diagnosis of many of the very sick patients, and it helps us in planning the treatment for these patients, and also execution of that particular treatment for these patients. And it also helps us to guide and to change the ventilator management settings depending upon the changes in the arterial blood gases. Now, there are very many parameters which you see in a normal arterial blood gas panel, but there are some parameters which are of profound importance to all of us. We have got two sets of parameters, the direct parameters, and then you have got another set of calculated parameters. The direct parameter is the pH, that is negative logarithm of H plus ion concentration in the blood. Then partial pressure of oxygen, or PaO2, is the second most important parameter. And the third one is the partial pressure of carbon dioxide, that is PaCO2. So these three are the most important parameters in the ABG. Then you can actually calculate bicarbonate value from the Henderson-Hasselbalch equation, that is H ion concentration into HCO3 by PaCO2. That will give you the roughly that will give you a calculated value of bicarbonate. Then buffered base, is it of value? The transatlantic debate continues whether it is useful, not useful. I'm not going into that, but still, when you look at an ABG, you can see buffered base values at the bottom of the panel. Now, coming to the normal values, the pH normal value is 7.40. The range can be between 7.38 to 7.42. PaCO2, the value is 40 millimeters and the range is 38 to 42 millimeters. PaO2 anywhere between 80 to 100 is the normal range. Bicarbonate is 24 plus or minus 2. I will put 24 milliequivalents as the normal value of bicarbonate. Then base excess is plus or minus 2 milliequivalents per liter. Now, we are supposed to read an ABG, that is arterial blood gases, should be taken from the artery. But sometimes we all know that we may miss the artery and we may hit the nearby vein and we will get a VBG. So how will you find out whether it is a VBG or ABG? We know that VBG lacks information about oxygenation. It is deoxygenated blood, which is there in VBG. So the PaO2 in a VBG will be roughly around 40. So it is very low. So that doesn't give us any information about the oxygenation of the arterial blood, but it gives a rather good estimates of the PaCO2 and pH. So it can be used, VBG can be still used for estimates of the PCO2 and pH. And also there is a relationship between ABG and VBG, that is peripheral venous pH is around about 0.02 to 0.04 lower than the arterial pH. So it gives us a rough estimate. Then venous PCO2 has got a wide range, that is 3 to 8 millimeters higher than the ABG PCO2. Venous bicarbonate comes to around 1 to 2 milliequivalents higher than the VBG. Now, I think this is an era of pulse oximetry doing rounds. So I'm going to ask you, is pulse oximetry good enough? Some people have tried pulse oximetry along with peripheral venous blood gases, and it has been tried in the emergency department across Australia, and they find it very useful, at least to some extent. At the same time, we should know the limitations of pulse oximetry. False high results can occur in heavy smokers, carbon monoxide intoxication, and in the presence of some strong lights in the room itself, you can get false high results, because this is actually recording the infrared beam radiating from the nails or from the finger pulp. So this can give falsely high results in some cases. Then falsely low values can also occur. For example, when you have a peripheral vascular disease patient who has moving fingers, tremors of the hands, nail polish, even mehendi put on the nails can give you very low values. Jaundice, then blood pressure variations can also be associated with falsely low values of pulse oximetry. Now, what is this COVID-19 situation and pulse oximetry? We are exploring the role of pulse oximetry in this era. The sales of pulse oximeters have gone up by 100%, double the sales in the last 3-4 months. They are being recommended for patients across the globe for monitoring oxygenation at home. And we all know that there is a entity called the silent hypoxia or the happy hypoxia, where patients come to the hospital and on recording they have a very low oxygen levels which are incompatible with life, but these patients present without any symptoms or dyspnea. So why these patients have got what we call a silent hypoxia? So many theories have been put forward. Low PCO2, actually it blunts the brain's response to hypoxia, as a result of which they don't perceive the dyspnea and they don't go into hyperventilation. Then effects of disease and age on the respiratory center controlling breathing, that also may be an explanation. For example, most of them are diabetes, elderly, so they have a blunted response. Then inaccuracy of pulse oximetry at low saturation. We all know that SaO2, that is oxygen saturation, SpO2, that is the oxygen saturation you get in the pulse oximetry, and SaO2 is the saturation of oxygen in what we get in the ABG. They can be roughly plus or minus 5%, and the SaO2, that is the arterial oxygen saturation, and the partial pressure of oxygen, they do not share a linear relationship. They have got what we call a sigmoid shape of the oxygen dissociation curve. So you have a plateau at the top. Then after that, around about 85 and so, there is a rapid fall in the saturation. I think I have got a picture of the oxygen dissociation curve. So we can know, we can see that the saturation, as it comes below 80%, it is less accurate because there is a steep fall in the oxygen saturation. And temperature, also temperature, that is a change from 37 degrees to 40 degrees. Many of your COVID patients are having a high temperature. So febrile patients can shift the oxygen dissociation curve to the right. That may also explain their reduced oxygen levels. And the mechanism supposed to be micropulmonary thromboembolism. And now coming to the ABG proper. So we should always analyze with due consideration of the patient's clinical status. For example, what is the diagnosis? And what are the presenting features? What treatment is he getting? Is he on oxygen? Is he on a ventilator? And what is the oxygen flow rate or the FiO2? All these things should be taken into consideration when you start analyzing the ABG. Now, before you start interpreting ABG, it's a piece of paper and so many numbers on it. First, I will ask my fellows to check the consistency of the report. I think that is the first step you can all do. You know that Henderson-Hasselbalch equation, where I have just modified that equation into such a form that H plus hydrogen ion concentration into bicarb by PCO2 should be equal to 24. And how will you get the H plus ion concentration from pH? That is a negative logarithm. So roughly, if you have a pH of, say, for example, 7.2, I have got one ABG of a diabetic ketoacidosis patient who has a pH of 7.2. So the H plus ion concentration will be 80 minus 20, that is 60. So you put that in the numerator, then bicarbonate is 15. So 16 to 15 by 30 is equal to 30. It is not 24. So don't even look at any further into that ABG report. So just throw it in the bin. So before you actually start looking at the values, check the consistency of the report, make sure that it is a properly done ABG. Now, arterial blood gases can be analyzed under 3 headings. The first one is the assessment of oxygenation. Second one is the adequacy of ventilation. Then only you look at the acid-base balance. So first we are looking at the oxygenation parameter. And we all know that the normal PaO2 level is between 80 to 100 millimeters. Hypoxemia is PaO2 less than 80 millimeters. And hypoxia is reduced oxygen tension in the tissue level or at the cellular level. Mild hypoxemia is between 60 to 79, where it is very unlikely that you will find tissue hypoxia. Moderate hypoxemia is between 45 and 59, where you may find tissue hypoxia plus or minus, whereas severe hypoxemia is defined as PaO2 less than 45, and you are sure to find tissue hypoxia all the time when the PaO2 is less than 45. And what is the relationship between age and the lower limit of PaO2? As the age increases, the lower limit of PaO2 or acceptable lower limit of PaO2 also reduces. For example, a patient who is 40 may have a lower limit of 85, whereas an elderly over 70 may have a lower limit of below 70. So 70 millimeters of PaO2 in an elderly person is acceptable as a lower limit. Now, what is this alveolar gas equation? It is very fundamental to the analysis of ABG. What it states is that sum of the volume in a confined space, if you have got two gases in a confined space, for example, carbon dioxide and oxygen in the alveolar confined space, the sum remains all the time constant. So if it is carbon dioxide which is going up, then it will naturally displace the oxygen. And another characteristic of oxygen is that it has got a gradient of diffusion. It always goes from an area of higher tension to an area of lower tension, whereas carbon dioxide is a very it doesn't have any gradient, it diffuses fast. So there is no difference between the alveolar carbon dioxide and the arterial carbon dioxide, whereas if you take the oxygen, there is a gradient from the alveolar oxygen to the PaO2. So just imagine an enclosed space as the alveoli. If your PaCO2, if it goes from 40 to 80, look at what happens to the alveolar oxygen. From 97, it goes down to 47, because sum of 80 plus 47, that should be a constant thing. Then there is a 10 millimeter gradient across the alveolo-arterial membrane, and so 47 can become 37. So when the PaCO2 goes up, you can imagine how much the PaO2 goes down up to 37. So that is what happens when you have the application of alveolar gas equation in cases of hypercapnia. Now, what is this AA gradient? I have already described that oxygen is a gas which has got a gradient through which it diffuses from an area of higher concentration to an area of lower concentration across the alveolar capillary membrane, and it is calculated from the formula PaO2, that is alveolar oxygen is equal to FiO2 into 720, that is the pressure, minus 47 minus PaCO2 into respiratory quotient. Actually, you can calculate roughly AA gradient is equal to age into 0.3. That will give you the AA gradient in numbers, but your ABG will always give you AA gradient calculated. It should always be calculated when you are very clear about the inspired oxygen. So FiO2 should be accurate, or you should be breathing room air. The FiO2 has to be there if you want to calculate the AA gradient. So better get it before you start your oxygen and other management. And the normal range up to 15 is taken as normal. It can vary. And in a setting of hypercapnic respiratory failure, a normal AA gradient suggests global hypoventilation. For example, as in an extrapulmonary cases like neurological or muscular causes, it is the pathology is not in the lungs, it is outside the lungs. Okay, global hypoventilation. Whereas a widened AA gradient above 20 is suggestive of an underlying lung disease like pneumonia or pulmonary edema. Then coming to FiO2 and PaO2, I think the ratio, PF ratio, I'm sure every one of us is very familiar. You have got PaO2 as a numerator and FiO2 as a denominator. So in a normal person, the ratio will be PaO2 100, FiO2 0.20. The normal is around 500. So PF ratio of 500 is normal, and it gives us an important idea about oxygenation, and it helps us to assess the severity of the problem and guides in the management. I'm sure all of us are familiar with the definition of acute lung injury, where the PF ratio is between 200 to 300. When it goes below 200, you will jump up the gun saying, oh, ARDS with bilateral infiltrates. Now coming to the adequacy of ventilation, the most important parameter to look at is the PCO2. PaCO2 is the best indicator of ventilation, and the equation is alveolar CO2 is equal to arterial CO2 is equal to VCO2 into respiratory quotient by the alveolar ventilation. And we all know that PaCO2 is inversely related to the alveolar ventilation. So when you have hyperventilation, you will blow up the PaCO2 and your PaCO2 will be on the lower side. When you have hypoventilation, your PaCO2 starts accumulating. So this is the flow chart in respiratory failure. I'm sure all of you can see it. So here is a patient who has hypoxemia. And what should you do next? Is PaCO2 increased or normal? If it is increased, then you think, oh, PaCO2 is increased, so it is hypoventilation. Yes. Then what else should you look at? The the alveolar arterial gradient. Is it increased? Yes. That means there is in addition to hypoventilation, you have another mechanism inside the lungs. That is what it shows. Whereas if the alveolar arterial gradient is normal, that means that hypoventilation alone is the cause for hypercapnia. It could be neuromuscular disease or reduced respiratory drive as in sedation or other CNS causes. Then if PaCO2 is normal, again you look at the alveolar arterial gradient. Is it normal? Yes. Then that means that it could be due to reduced PaO2 in the inspired air. For example, in high altitude or in reduced FiO2, this may be normal. So if the PaO2 is correctable with oxygen, yes, it means VQ mismatch, as in airways disease like asthma, COPD, alveolar diseases like pneumonia, pulmonary edema, and so on, pulmonary vascular diseases. So they all account for high alveolar arterial gradient with low PaO2, which is correctable with oxygen. If the low PaO2 is not correctable with oxygen, you will think of all the shunt. For example, the intrapulmonary shunts or the intracardiac shunts. Now, the third part of the ABG analysis is assessment of acid-base balance. The stepwise analysis of ABG is done. The first step, I think I'll go on to the steps. So first, you look at the pH and say whether it is acidosis or alkalosis. So normally 7.40. pH less than 7.38 is acidosis. pH above 7.42 is alkalosis. Simple. And then you go on to the next step. Is it respiratory or is it metabolic? And remember the Henderson-Hasselbalch equation. I have modified it as kidney by lungs. So kidney is bicarb and lungs is PaCO2. So pH is equal to bicarb by PaCO2. So reduced pH, that is acidosis, can occur when the denominator goes up. So respiratory, PaCO2 goes up also, you can have acidosis. Also when the HCO3 comes down, for example, metabolic. So pH lowering, acidosis can occur due to PaCO2 increase or bicarb decrease. So respiratory will be PaCO2, respiratory acidosis, PaCO2 will be more than 40. In respiratory alkalosis, it will be less than 40. So if you are sure about it is respiratory acidosis or alkalosis, you go on to step 3. Before that, step 3. What is step 3? You have a respiratory problem. It can be acidosis or alkalosis, but you need to know whether it is an acute problem or chronic problem. Acute respiratory problem, they will be accompanied by large pH change because kidney is a slow goer. So kidney takes more time for compensation, like days to weeks. So the pH change in acute will be large. So for example, in acute respiratory acidosis, if you have a PaCO2 of 70, So what is the pH change you expect in acute respiratory acidosis? What is the change in chronic respiratory acidosis? So it is 0.08 in acute. PaCO2 is 70, 70 minus 40 divided by 10. So 3 into 0.08, that is 0.24. So you reduce 0.24 from 7.4. So the pH will be 7.16. Whereas in the same patient, if you are thinking in terms of chronic respiratory acidosis, it will be 0.03 into 3, 0.09. So 7.4 becoming 7.31. So it is a small pH change you get in chronic respiratory acidosis. Same way in alkalosis, the pH goes up by 0.08 in acute. Chronic respiratory alkalosis, the change is small. The pH goes up by 0.03 into the change in the PaCO2. So acute on chronic and chronic. So chronic, it is 0.03 into change of PaCO2. In acute, large change in pH, 0.08 into change of PaCO2. So somewhere in between 0.03 and 0.08, you have acute on chronic. Now, coming back to, so respiratory, you have one more thing, compensation in respiratory. I think I will explain the metabolic thing. So before we go on to the compensation, I will discuss compensation together in respiratory and metabolic. So yeah, step 2, you have finished with your respiratory. So if you think metabolic, bicarb is the culprit, reduced HCO3 to less than 24 is metabolic acidosis. More than 24 will be metabolic alkalosis. So if it is metabolic acidosis, you go to step 4. If it is metabolic alkalosis, you go to step 6, where you look for, is the compensation adequate or not. So when metabolic acidosis is present, the next question you have to ask is there an anion gap, and what is the anion gap? So what is this anion gap? It is the quantity of anions not balanced by cations. So you have sodium in one side and chloride and the bicarbonate on the other side. So the normal anion gap comes to about 10 to 12 millimoles per liter. It is usually due to the unmeasured plasma proteins, as the charges of other unmeasured cations and anions tend to balance out. So the normal measured anion gap is 12 milliequivalents. It is sodium plus ions minus chloride plus bicarb. That is 12 milliequivalents. If you look at the unmeasured anions, that is the proteins, the organic acids, the phosphates, sulfates, that totaling to 23. And the cations like calcium, potassium, magnesium, they also total to 11. So the difference is 12 milliequivalents. So this measured anion gap and the unmeasured anion gap is almost equal. So what is this high anion gap metabolic acidosis, where the anion gap is more than 12? The Mulipack mnemonic is there. Methanol poisoning, uremia, lactic acidosis as in sepsis or LVF, ethylene glycol poisoning, paraldehyde poisoning, aspirin toxicity, diabetic ketoacidosis are classic examples of high anion gap metabolic acidosis. And mind you, anion gap metabolic acidosis can occur in some conditions where the actual measurable anion gap may be normal. Still, you will call it a high anion gap. For example, in cirrhosis, nephrotic syndrome and malnutrition, where the culprit is hypoalbuminemia, contributing greatly to the unmeasured anions. Now, what are the causes for normal anion gap metabolic acidosis? Metabolic acidosis with anion gap less than 12, the classic example is where you lose bicarbonate from the gut, as in diarrhea, or it can be excess loss from the kidneys, which you see in the renal tubular acidosis. Then when you use acetazolamide, hyperalimentation, there all you get normal anion gap metabolic acidosis. Now, we are moving on to step 5. See, you have diagnosed high anion gap metabolic acidosis. You have to know whether other metabolic disturbance coexist with a high anion gap metabolic acidosis. For that, you calculate the anion gap and you look at the corrected bicarbonate. So what is this corrected bicarbonate? So it is a measured bicarbonate plus the patient's anion gap minus 12, the difference in the anion gap. If you add on to the measured bicarb, you will get the corrected bicarb. If the corrected bicarb is 24, that means there is only purely anion gap metabolic acidosis. If it is more than 24, that means there is associated metabolic alkalosis. If it is less than 24, there is another acidosis, that is normal anion gap acidosis. So I will come to the delta gap later. So this tells you what associated metabolic disturbance is there along with anion gap metabolic acidosis. Now we are moving on to the compensation, that is step 6. So let us take the metabolic disturbance first. So what happens when you have increased bicarbonate? Increased bicarbonate you get in alkalosis, metabolic alkalosis. So it will produce an increase in the PaCO2. Then what will happen when you have decreased bicarbonate or acidosis? It will again produce hyperventilation and wash off the PaCO2. So this formula, Binder's formula, helps us to calculate what is the PaCO2 in expected PaCO2 when you have acidosis, metabolic acidosis. So how will you calculate this? I think I have the formula is 1.5 into bicarbonate value plus 8 plus or minus 2. The PaCO2 will fall by 1.5 for every 1 milliequivalent of bicarb. So I will have an example. Suppose a patient has got metabolic acidosis, the bicarbonate is 10. So how will you calculate the corrected or the expected PaCO2? It is 1.5 into 10 plus 8 plus or minus 2. So the range is between 21 to 25. So if the measured PaCO2 is less than 20, that means there is associated respiratory alkalosis in addition to the metabolic acidosis. Okay, if the PaCO2 is more than 25, that means the PaCO2 is up because of a coexisting respiratory acidosis. So that is how you analyze the respiratory compensation. If the PaCO2 is between 21 and 25, it is adequate compensation for metabolic acidosis. So if it is less than 21, it is respiratory alkalosis. If it is more than 25, associated respiratory acidosis. Okay, now what is the respiratory compensation in metabolic problems? That is metabolic alkalosis. Here it is 0.7. So for every increase of 1 milliequivalents, your PaCO2 will also increase by 0.7. Okay. So we saw that the compensation is always in the same direction as the primary abnormality. Now, what is the metabolic compensation in respiratory problem? We already know that we discussed in acute and chronic respiratory acidosis. Here, PaCO2 is going up. So for every increase in 10 millimeters of PaCO2, the bicarb will also go up by 1 in acute, by 3 in chronic. So you can see that the change here is more in chronic. In respiratory alkalosis, the PaCO2 goes down and the bicarb will also go down. So it will be 2 milliequivalents or 2 milliequivalents for every 10 millimeter fall of PaCO2 in acute respiratory alkalosis. In chronic, there is a giant change of 5 milliequivalents of bicarb for every 10 millimeter fall of PaCO2. So respiratory acidosis acute, it is 1, chronic, it is 3, whereas alkalosis, it is 2 and 5. Now, rules of compensation. Here also, the lung overtakes the kidney. Respiratory is faster. It takes only few hours, whereas kidneys take days to a week at the most. Compensation always depend on how good your lungs and kidneys are and severity of the acid-base disturbance. And I have already discussed that compensation is always in the same direction as the initial disturbance, and it may be rare to see complete compensation. Now, what are the clues which you can pick up whether there is a combined problem or is it just a compensated problem and so on? If all the values are abnormal in the same direction, that means it is a combined problem. If the pH is normal, that means it is already a compensated problem. The PCO2 and HCO3, they are all both abnormal. So it is a fully compensated problem if the pH is normal. If the pH is abnormal and PCO2 and the bicarb are both abnormal in different directions, that means it is a partly compensated problem. Then, when will you suspect mixed disorders? If PCO2 and bicarb, usually they move in the same direction. So compensation is always by movement in the same direction. You suspect mixed disorders when they move in the opposite direction. For example, pH is 7.25, that is acidosis. So what is the culprit? PCO2, yes, 60. That is respiratory acidosis is the bicarb 16. So metabolic acidosis. So you have got a mixed acidosis. So what will you do next? So you have to see which is the dominant one. So is it 60 minus 40, that is 20 by 40, or is it 24 minus 16, that is 8 by 24? Which is the dominant? It is respiratory acidosis. So here you have mixed acidosis with respiratory acidosis as the dominant abnormality. Now the gap ratio, that is difference in the anion gap over difference in the bicarb, is 1 in high anion gap metabolic acidosis, whereas the ratio is less than 1 in combined high and normal anion gap metabolic acidosis. The ratio will be more than 1 or more than 2 when associated metabolic alkalosis is there. And coming to metabolic alkalosis, there are two different types of metabolic alkalosis. One is chloride responsive and the other is chloride resistant. Chloride responsive is the one due to vomiting, chronic diarrhea, diuretic use, post-hypercapnic compensation. And the chloride resistant ones are associated with severe hypokalemia, mineralocorticoid excess, as in ectopic ACTH, Cushing's, secondary hyperaldosteronism occurring in CCF, so on, where fluid correction is not going to help you to correct the metabolic alkalosis. Now, this is roughly the approach to a patient with a normal anion gap acidosis. So if you have a normal anion gap acidosis, look at the urinary anion gap. That is urinary sodium plus urinary potassium minus urinary chloride. If the value is positive, then you look at the pH. If the urinary pH is more than 6, type 1 renal tubular acidosis. If the pH is less than 5.5 with a low potassium, it is type 2 renal tubular acidosis. And if it is high potassium, the Barter's or type 4 renal tubular acidosis. Respiratory alkalosis, the causes can be a direct stimulation of central respiratory center in the form of fever, pain, anxiety, and so on. Or it could be a stimulation of the peripheral respiratory center as occurring in pulmonary embolism, pneumonia, and so on. Mixed mechanism can be there with salicylate poisoning, thyroid hormones, cirrhosis, sepsis, pregnancy, etc. The symptoms can be neuromuscular, where you can get tetany, twitching, lightheadedness, syncope, and so on. Cardiac, like tachycardia, arrhythmia, nausea, vomiting may be there. Then coming to acute respiratory acidosis, the causes can be either excretory or in the control component problems. Acute respiratory acidosis, as you all know, cardiac arrest, severe pulmonary edema, all kinds of airway obstruction, upper airway as well as lower airway obstruction, severe pneumonia, myasthenia crisis, pneumothorax, flail chest. Then control components can be drugs, sedation, anesthetic agents, spinal cord injury, strokes. And the manifestations, delirium, varying stages of stupor and coma. Patient may complain of headache. They can have astraxis, papilledema. They can also present with seizures and myoclonus. Chronic, the cause can be excretory component like problem with ventilation as in COPD, advanced ILD, or a restriction of the thorax as in kyphoscoliosis or muscular dystrophy. The control component is affected in OSA, obesity hypoventilation syndrome, myxedema, amyotrophic lateral sclerosis, bulbar polio, multiple sclerosis, and diaphragmatic paralysis. I'm just rushing through this because I need some time to discuss some problems later on. So I will just stop this presentation with 10 commandments of ABG. Use only minimal amount of heparin. The heparin found inside the needle, about 0.025 ml of heparin is enough to anticoagulate the 1 ml of blood which you take. And if possible, you can do a modified Allen's test to make sure that there is collateral circulation, and make sure that there is no air bubble in the blood taken, and the sample should be analyzed as soon as possible. Plastic syringe is enough. You don't go for glass syringes. It should be properly mixed, and we should always take into consideration the FiO2 when interpreting the PaO2 values. And history of the patient and ventilator settings are very important before you start analyzing the ABG. Think of DOP if sudden deterioration in the ABG, for example, displacement of the tube or obstruction of the tube or a pneumothorax or an equipment failure may be the reason for sudden deterioration in the ABG values. Treat the patient and not the ABG. So patient should be given the importance, not your piece of paper, and always clinically correlate the ABG. So I am moving on to the case studies. So this is a 69-year-old female who is a known case of COPD who presented late in the evening to the ER with complaints of dyspnea since 1 week, associated with cough and expectoration, wheeze and headache. On examination, patient was talking, conscious, fully oriented, blood pressure, pulse rate of 102, respiratory rate of 28, SpO2 was 94% with 5 liters of oxygen. So these were her gases in the ER. So first we will look at the oxygen. PaO2 is 80, which is normal, but FiO2 is 5 liters of oxygen. Oxygenation is carried out with oxygen supplementation. Now, look at the carbon dioxide. PCO2 is high, 78.4. So there is hypoventilation. Now look at the acid-base balance. pH is 7.183. So there is acidosis. Who is the culprit? It is raised PCO2, 78. And you can also see that the pH changes more. So it is 0.08 into 40 by 10. So 4 into, so roughly it corresponds to acute respiratory acidosis. And what is the compensation in acute respiratory acidosis? The bicarbonate should go up by 1. So from 24, it has gone up to 28. So this is acute respiratory acidosis, partially compensated. Now, later on, this patient was admitted in the intensive care unit, started on BiPAP. She improved in the next ABG, but later in the night, she complained of increasing dyspnea and she became drowsy. A repeat ABG at this time shows pH of 7.094. So there is marked worsening of the pH. The PCO2 has gone up to 91. The patient has become drowsy. So at this point, the bicarb is just 26.7, means it is not even starting to compensate. So the patient was intubated, put on volume control ventilation, tidal volume of 400 ml, PEEP of 5, respiratory rate of 22, FiO2 of 50%, and she improved dramatically. And she was kept on ventilator support for 2 days. After 2 days, these were her ABGs. So look at the pH, 7.486. So it is alkalotic range. PCO2 is 39.8 and PO2 is 104. She is on FiO2 of 24%. Saturation 98.7, bicarb. Look at the bicarb, it is going up 29.7. So she was extubated with this ABG. So you can see that the ABC change from hour to hour, and it also changed with the treatment. So successfully treated patient with abnormal ABG. Now this is an interesting case. 58-year-old lady who is an operated case of CA pancreas. She was admitted to the ICU with an acute respiratory distress of 1 day duration. She has no fever, just dyspnea of 1 day duration. The X-ray chest showed bilateral patchy shadowings. Is it ARDS? That was what we were thinking. Echo showed normal LV function. And what was her blood gases? So first look at the PaO2, 64. So it is on the lower side, and her saturation is 88. So that is also on the lower side. Now, what is the PaCO2? It is 32. So she is hyperventilating. And what is the pH? Acidotic pH, 7.25. So what is the culprit here? It is metabolic acidosis. Bicarb is 14. So you have bicarb of 14 producing acidosis. So she has metabolic acidosis, severe metabolic acidosis. Now, how will you proceed from here? So what you do next is you calculate the anion gap as well as the expected PaCO2. So in this patient, the PaCO2 recorded is 32. So what is your expected PaCO2? It is that Winter's formula, 1.5 into 14 plus 8 plus or minus 2. So that comes to about 31. So the value is 32. So this is pure uncompensated severe metabolic acidosis. Now, next will be what is the anion gap? Anyway, the patient was put on the ventilator. She improved. pH became 7.44. PaO2 improved with an FiO2 of 60. Next day, her ABGs are showing mild respiratory alkalosis, and still there is evidence of metabolic acidosis in the form of reduced bicarb of 18.9. Right, on 15, that is about 1 day after this, she was found to have desaturation while on ventilator with hypotension. Look at the ABGs. There is acidosis, marked acidosis, 7.167. Who is the culprit? It is PaCO2, 70. So it is acute Hello? Can you hear me? Are you able to hear me?
Yeah, we are able to hear, right?
Yeah, I'll continue. So there is respiratory acidosis and acute respiratory acidosis because the change in PaCO2 from 40 it went up to 70, and there is a marked reduction in the pH from 7.4 to 7.16. So it is acute respiratory acidosis. So what was the culprit here? The X-ray chest revealed a pneumothorax on the right side, and there was another consolidation on the left side. So this has precipitated acute respiratory acidosis in this patient. We did an ICD on the right side and started or changed the antibiotics, and she improved on the ventilator. And see her ABG on the next day, it is 7.52 with PCO2 of 26.8. And so that is respiratory alkalosis, and she was extubated in 2 days' time. So case number 3 is 84-year-old female who is complaining of weakness and vomiting for the last 1 week. Right, so look at the ABGs. pH is 7.4, PCO2 is 40, PaO2 70 for that age, 70 is okay. Bicarb is 24. All the ABGs appear components are all normal. So what is the problem? I think the clue is you calculate the anion gap. So 142 minus 96 plus 24. So that is 142 minus 120. The answer is 22. So she has an anion gap, and this is anion gap, high anion gap metabolic acidosis. So then why is her pH 7.4? So there should be something more than that. So for that, you have to calculate the corrected bicarb. How will you calculate the corrected bicarb? You add the bicarb, which is a measured bicarb, plus the patient's anion gap, 22 minus 12, so 10. So 24 plus 10 will give you a corrected bicarb of 34. So there is associated metabolic alkalosis due to the vomiting. So she has 2 metabolic abnormalities which made the ABG look apparently normal. Okay. Now, here is a patient, 62-year-old male, who is complaining of tiredness of few days duration. In fact, he was admitted in another hospital and was diagnosed as OSA with type 2 failure, and he was advised BiPAP. And the patient was not fully convinced. That is why he came to us. So what is the ABG showing us? So the pH is 7.343. So it is acidotic pH, but the change in the pH is small. So it looks like a chronic acidosis. What is the culprit? PCO2 is a culprit. So PCO2 has gone up from 40 to 70. So it is chronic respiratory acidosis. Oh, the PaO2 is 45, SaO2 is 75, and the patient's saturation was in fact 86. So this is chronic respiratory acidosis and a mixed. So this can be a mixed sample. It need not be a pure ABG. It can be a mixed sample because the PaO2 is so low, nearing 40, as well as the saturation in the ABG is 75, whereas the pulse oximetry SpO2 saturation is 86. So that wide variation is there. So this could be a mixed sample, or even you can take it like a VBG. But we were not confident about the diagnosis of making OSA because he was thin. He did not give any history of daytime sleepiness or excessive snoring and all. When we went into detail, this patient said he will go cycling in the morning. By the time he comes back home in the evening, he will be tired. Some days he is perfectly fine. Some days he is very tired. So this kind of variability is typical of myasthenia. So this was actually a myasthenia case presenting with chronic respiratory acidosis. So very important to take a proper history before labeling them as OSA or COPD and type 2 failure. And this case 5 is an interesting case. This is a case which I have taken from the NEJM series of ABGs. She is a 47-year-old female with fever, vomiting, and anuria of 24 hours duration. She has a past history of advanced CS cervix. Her medications include only opioids and paracetamol. On examination, she was febrile, heart rate was 134, SpO2 was 100, and she was breathing room air. The total count was 44,000, CRP 52, chest X-ray was normal. Ultrasonogram of the abdomen showed bilateral hydronephrosis, urine culture grew E. coli, and the pH is 7.32. So we will just go through the parameters. pH is 7.32, so there is acidosis. Look at bicarb. So there is definitely metabolic acidosis. But look at PaCO2, 12. Both are reduced in the same direction, which is very unusual, isn't it? So I would like to do the whether these values are actually correct in the first place. So 7.32 is the pH. The H ion concentration will be 80 minus 32. That is 48 into 6 by 12. Oh, that is good. 48 by 12. That is 4 into 6 is equal to 24. So these numbers are correct. They are not wrong. So when I saw the things first, marked reduction in PaCO2, markedly reduced bicarb to 6. So these were, so these values are correct. So I would like to go ahead with analyzing this. So there is acidosis, there is metabolic acidosis. So what will you do next? Look at the anion gap. So what is the anion gap? So high anion gap of 45. So she has a high anion gap of metabolic acidosis. She must be having sepsis, lactic acidosis from the UTI. She has anuria, so renal failure. So all this contributing to her high anion gap acidosis. Now look at what her expected PaCO2. We have got 12 into, so her bicarb is 6. So what is the expected PaCO2 using the Winter's formula? It is 1.5 into 6 plus 8 plus or minus 2. So the PaCO2 should be between 15 and 90 if it is only metabolic acidosis. But here it is 12. So it is less. That means there is associated respiratory alkalosis in addition to metabolic acidosis. Then what is the other thing? What is the delta anion gap, delta bicarb? So 33 by 18, it is more than 1. So there is an additional metabolic alkalosis. And another abnormality which you all found was there was an AA gradient of 22.5. That itself indicates there is a relative hypoxemia due to sepsis. So additional metabolic alkalosis. So you have got triple disorder in this patient. So another patient, 68-year-old male smoker who has come with dyspnea and cough. The pH is 7.35. So there is only minimal change in the pH. So it is chronic acidosis. PaCO2 75 is the culprit. So it is chronic respiratory acidosis. You will treat the patient before jumping into putting the patient on BiPAP. If the patient is improving, you may get away without using BiPAP. So I think I have come to the end of my presentation. ABG is a very useful tool if analyzed properly in a stepwise manner and always along with clinical findings. Thank you for your patient listening.
Good evening, Shoba madam. Good evening, Shoba madam.
Evening,
Can you
Thomas.
hear me?
Yeah, I can hear you, Thomas.
Yeah. On behalf of Pulmo team Amla, we would like to thank you and congratulate you. The presentation was excellent, and I think it covered all points in blood gas analysis, and it was very useful presentation. The clinical scenarios you have given, wonderful clinical scenarios, and I think the topic was very useful for us and all PGs and residents who are attending this program. And thank you for your association with our lecture series. Now the topic is open for discussion. I request Sudhir to unmute all the delegates.
Questions. Where will I get the questions?
Yes, sir. The participants.
Dr. Shoba madam, Dr. Ennis, can we do VBG for monitoring of a type 2 respiratory failure instead of ABG? Can we go ahead with after initial ABG, whether we can monitor a patient of COPD with type 2 respiratory failure with the VBGs, just venous blood gas with SpO2 as we were telling you?
Yeah, pH and PCO2, rough idea is given by the VBG, but it doesn't tell us about the oxygenation. So oxygenation status will not be clear in VBG. So I don't think we can go ahead by only looking at the VBG in COPD exacerbations.
Once we get the initial ABG, it's always very easy to get the venous blood. So whether the monitoring can be done with our SpO2 and VBGs in a type 2 respiratory failure, whether it's possible. There are a few studies, I think so.
Yeah.
It should be useful, right? What's your comment on it? Yeah.
It can be used to some extent only. BBG will not replace the ABG completely.
Any questions from the participants?
Participants can unmute the mic and you can ask queries.
I think the topic was very elaborate and no doubts at all. I think that may be the reason for no questions.
It can be otherwise also, Thomas.
No,
But
ma'am, it was very good.
Understandable, no issues. Either it's all or none phenomena.
Yeah, that's
probably
right.
they have understood everything. That's why.
Right. Can I add a few words?
Yeah, sure.
I am deeply grateful to the Amala team for asking me to come and talk on ABG, my pet topic. And thank you so much, Rennis and Thomas, for asking me to do this.
Now, our idea from pulmonology department, our idea is to keep a platform from South India on critical care. So your institution, one of the premier institution in the South India, we are grateful to you to join our sessions, and we are really thankful for you. And we will keep updated the other topics also for your PGs as well as our PGs. As well as it has taken, I mean, gradually it will be progressing to other parts of the Kerala as well as South India. We are we have made a start, and we want to know whether how the technically it's feasible, and how is it working around. So we will get it improved. And sorry for some technical delays or some few participants being entered. I don't know how they have, whether they were able to get into the sessions. I don't know. I will have the feedback later on only. Last time it was okay. It was just, but there were a few technical issues again, which we have corrected this time. This time, actually, all the participants are free to ask any questions, and it can be a kind of two-end sessions. I mean, our guest is ready for answering your questions. And last time it was not so because of some other service provided. So this time onwards, Sudhir, Emmy, Edison, all from Cipla team has really taken a pain for getting all the technical issues out of our reach. And the audio, video, everything was fine, and your talk was really superb, and it was precise and getting into 1.5 hours. Thank you very much, ma'am. And these topics will be again going ahead with around 30 topics. The new brochure with all the speakers will be provided to all the senders in the next week, probably. Thank you, Cipla team, and also Dr. Shoba ma'am, for taking your valuable time for being in Amala once more.
Oh, thank you. It was a pleasure.
Thank you, Renny sir. Thank you, sir.
Thank you, sir. If anyone has any questions or they would like to connect, they can just either put it down on the chat so that everyone can have a look at it, and the questions can be answered on the chat or they can be answered verbally by the doctors.
ചോദ്യം ചോദിക്കണമെങ്കിൽ ടൈം അതിലാണല്ലേ അതിലടിച്ചിട്ട്.
No, I think there is no question. And Ami, one more thing, this recording link will be getting, na?
So as soon as this is over and I stop the recording will get saved on the chat with a link. So you can share the link.
Okay, done. So the entire presentation, Renny sir, Shoba madam, now we have already recorded and we will be sharing the recorded link. So those who are not able to attend or those who are not able to watch this presentation, you can forward again.
This link will be only for this week, right?
Yes.
For next topic and the next talk, it will be a different link, it seems. But it will be same, the Microsoft
No,
Teams.
question this Microsoft link, what we have prepared. So the next meeting, it will be the same or we'll be creating another link?
You can keep the same link, no problem.
Okay, it's the same Microsoft Team app, right?
Yes.
Yeah.
Okay.
You can join in on the same link, no problem.
Okay, if you change it, then let me know, because we have given the link to almost all the participants, and we want to extend it further. So if there is any change in link next week, let me kindly know. Okay.
Yes, sir. Yes,
Yeah.
sir.
The whole Supla team for behind the curtain. Thank you very much.
Thank you, sir. Thank you.
Thank you. Y'all can leave the group if you don't have questions. Thank you very much for attending.